see a pharmacy every 3 shops. Is that normal?
No. And you also probably see pharmacies that are hugging government hospitals.
Yeah.
You see at the entrance of... I mean,
Yeah.
Kiruddu is like the perfect example. But even Mulago, you have a government hospital.
Just at the gate?
That should be providing, pretty much everything that is needed. And then you have at the gate, and on either side of every gate and opening, you have a pharmacy.
Yes.
Or maybe even a lab, providing the exact same services that should be in there, that is private. Yes. In fact, not too long ago, they also had started having private pharmacies within hospitals.
Wow.
Yes. And I think the president said something and people complained, and so they said, no, maybe this is going too far. Yeah. But it tells a story. So when you have government and when you have, in Uganda we say that there should be essential medical services. Essential services that if you pay your taxes, if you're living within the confines of this country, that you should be able to access. And in fact, there is, and by the way, talking about Genius, it was a Ugandan that first came up with an essential drug list.
Yes. The one
that eventually was, Charles Olaine, Professor Charles Olaine. So anyways, so you have that. And unfortunately, because we do not invest where we should, then you have all these private interests that know that
money can be made.
Money can be made, and it is being made. And because of the obvious conflict of interest, or the potential for conflict of interest, you want to avoid that. In fact, the Director General of Health Services, I think less than a week ago, maybe a week ago, came up with, now there's going to be guidelines to how close a private pharmacy can be to a hospital.
Behind every book is a hidden story, a conflict, a question unresolved, a dream waiting to be told. On Voice in Print, we uncover the minds behind the words, exploring the writing process, the creative bursts, and the quiet obsession that drives authors to transform fleeting thoughts into lasting pages.
Welcome back to part 2 of Voices in Print podcast. And like I said earlier, I have this book with me and the amazing author, Dr. Olive Kobusingye. We've looked at the history of Uganda's medical sector, starting right from colonial times to the 80s. And now the part 2 will pick it right from there. So doctor, let's get to the 80s. The 80s is the time that is known around the world, not just Uganda, when the AIDS pandemic hits like a bomb. I must confess, I wasn't born, but from what I've read, it must have been, and my experience with COVID, it must have been such a very terrible time for anyone living, especially in this part of the world, and also for medical people particularly. So how does the coming of HIV affect Uganda's health sector in the 80s as per this book?
Thank you very much, Godwin. This gives me an opportunity to actually point out the... what is it called? The tagline for the book. The book is called The Patient.
Yes.
But it does say sacrifice, genius, and greed in Uganda's healthcare system. Yes. And I think it's in the 80s that, all through the book, you see those three. You see the sacrifice, you see the genius, and you see the greed. Yes. But I think it's in the 80s that we see those three really come together in ways that one would not have anticipated. So you're right, the 80s were, in terms, it wasn't, I don't know, I guess every so often, maybe it's cyclic, that something happens that really shakes the foundation of society, of a system. And AIDS did that. HIV AIDS did that in all ways. So while it was for people working in the healthcare system, it was a disease or a syndrome, meaning that there were many different things that would go wrong. But it wasn't just that people were sick. It was that people were not able to work. So the economy took a hit. It was healthcare became more difficult to deliver. And we had to deal with things like, how do we where do we treat people? How do we deal with kids? And so on and so forth. In fact, in the book, I talk about how at Mulago, once the patients started coming in, and remember, with hindsight, we know when somebody has HIV, and even if they should develop AIDS, what do we expect? Remember back then, everything was being made up as we went along. Nobody knew what to expect. Nobody knew what the symptoms meant. Nobody knew what the bloods, it was all very new.
I can imagine.
It was all very new and frightening. And I talk about how health workers responded to this threat. On the one hand, you care, you deliver care. You don't abandon patients. You research or you investigate patients, but you've now come to learn that your closeness to the patient might lead to your own, contracting the disease that you could die of. There was no treatment. There were no ARVs. There wasn't even a good understanding of, when you're investigating this patient, what exactly do you do? What do you take? Exactly, what are you looking for? So it was a very frightening period for those that were in healthcare and in research. And the reason I remind you of sacrifice, genius, and greed is that there was tremendous sacrifice for the people that were caring for patients. Whether they were nurses, they were doctors, they were lab techs, there were public health people that were now, or people that went into research. There was tremendous sacrifice to try and figure out, how do we treat people? How do we sustain their health? Or if we can't cure them, how do we treat them with dignity until they go? And why I talk about genius is that then the researchers started coming in, or even ordinary clinicians started realizing, okay, so this is what we need. This is what we've observed. This is what it means. This is how. So they started piecing these things together to try and come up with a working diagnosis with how do we train those that are coming in to recognize and to deal with this kind of disease.
Wow. Must have been hard getting that from the scratch.
Then comes the greed.
The greed.
And the greed didn't come. I guess we didn't see it coming, but, people started to, the profiteering, realizing, because once there's this terrible threat, and it's not just about it, it's human and it's in all aspects, is that people...
There's a saying that don't let a good crisis go to waste.
There were lots of people that didn't let that go to waste, unfortunately. So you can see in the book the kind of things that would happen, with those that suddenly saw this is the opportunity, because there was money pouring in, as you recall, or you wouldn't, you weren't born yet. But so initially, Uganda was one of those that came out did quote unquote the right thing, came out and said, we have a huge problem, people, we have a huge problem on our hands.
What I've read is that the president said, I am a soldier and this is a war. So we're going to handle this like a war. We're going to war with HIV.
Right. So Uganda came out with their, abstinence, with their, with their, yes. And it was hailed as having saved lots of lives, and I believe that it did.
Yes.
While other countries were still trying to, hush and not admit that they had a problem. Yeah. And with that kind of openness around this issue, we got lots of international attention, most of which was positive, that people would come out here to help with the research, to help with the care. Of course, even that, eventually you realize that there was an element of maybe it's not all, I'm not rushing there to help poor Ugandans, but this is an opportunity to publish more work, to be known as the one that, so there's always that, unfortunately. But I think the greed is what really, you sit back and you say, people were profiting over, those that most desperately needed help. Yeah. So, for instance, in terms of the healthcare, doctors, nurses needed protection.
Yes.
You remember the protectives in COVID, like
Yes,
how
yes,
it became a really big deal that,
Yes.
doctors and nurses and all other healthcare workers would
Standard
get
operating procedure, SOPs.
yes, and protectives of all sorts. So this, one would have thought we could take for granted. No, it then government dragging its feet, money is being released to buy gloves. I remember as a medical student and as a young doctor rewashing gloves. Like now, it's
reused.
absolutely, you don't want to think about it. Yeah, but we reused gloves. We reused gloves, we washed them, and then, they would powder them and stuff. And this, so we will never know how many other people contracted HIV that shouldn't have if we had put in the right protectives. Yeah. And a lot of that had to do with people that should have known better profiting from the crisis. Yes. So it was a very difficult decade. And one, I talk about some of the people that were at the forefront of that, and what it meant for our healthcare system. And also how Uganda, in some ways, had a leading role in research on HIV/AIDS.
So before we get done with the HIV bit, the more recent statistics that I see in the newspaper say that, again, it's going up. We probably contained it to a level that maybe was not the best, but yeah, we're doing something. But now the statistics seem to show that, again, HIV in Uganda currently is going way up. From a medical perspective, of course, that's not in the book. What's causing that?
This is not my field, but from what I understand is, I think a number of things that have been allowed to happen. So, for instance, even amongst the population, once ARVs came and people are living longer and healthier lives, I think there's been some laxity, complacency, and people not being aware that just because this person looks healthy, they might be transmitting. There've been issues with young people that maybe don't have, we were terrified once we understood how HIV/AIDS was transmitted. But I think that kind of terror maybe is not being, people are not understanding just how dangerous it is, for instance, to have multiple partners. Unfortunately, very young people, so I think there are a number of things that maybe Ugandan society has dropped the ball on. And of course, now we have the very present danger of ARVs being
cut by the funding.
Right. So
that's that. Okay, so let's move from that now. But before we go, so my friend read that book around the time I read it. We bought the copies together. And then he said, this book is a very sad book to read. You read and at one point you want to cry. But then he said, but also the author has this part where she narrates very interesting stories. So you write that one of the doctors at Mulago, the money that comes in from donors, he buys a car and then he drives to town, to a bank. After his transactions in the bank, he walks as he would do until that point and takes a taxi back to Mulago.
Right.
Then he realizes that his car is missing. Then the police are called in, and the police do the basic of search, and they say, wait, it seems we found the car. But he realizes that he had left the car. He had forgotten about his car that he had just purchased. So now, if that doctor had that good boom, and there were many, was that a positive thing for the Ugandan healthcare at that point, especially from the angle of the training? Yeah, you talked of all these people who are coming in for the research.
Right.
How does that then translate at Makerere University?
Yeah, so there was a time, when things were looking up.
Yes.
When now we turned a leaf, there's no war. People are beginning to come to Uganda and to feel safe here. And even Ugandans are living in the diaspora beginning to think, I can go home and make a difference and give back. And so there was beginning with HIV/AIDS, there was a lot of money that was coming into the country in research, research grants, and so on. And so I think there was indeed that time when the things were beginning to really look up. And as I said, training, clinical practice, and research usually go hand in hand. So I think what happened then, and what unfortunately continues to happen now, is that you have health workers that are only looking after patients. They're not researchers. You have health workers that then become researchers, and they realize that actually being in research is probably more lucrative than being taking care of patients, right? And remember that it's around this same time that then private practice begins to take off in a very different way. Previously there was government, and then there was mission hospitals.
Yes.
And there were private clinics, but they weren't a big thing. Yeah, but over the last 20 maybe, this has completely changed.
So the neoliberal era.
This has completely changed.
Private schools now,
right?
Private healthcare. So talking about that, I see a pharmacy every 3 shops. Is that normal?
No. And you also probably see pharmacies that are hugging government hospitals.
Yeah.
You see at the entrance of, I mean, Kiruddu is like the perfect example. But even Mulago, you have a government hospital.
Just at the gate.
That should be providing, pretty much everything that is needed. And then you have at the gate, and on either side of every gate and opening, you have a pharmacy.
Yes.
Or maybe even a lab, providing the exact same services that should be in there. That is private. Yes. In fact, not too long ago, they also had started having private pharmacies within hospitals.
Wow.
Yes. And I think the president said something and people complained. And so they said, no, maybe this is going too far.
Yeah.
But it tells a story. So when you have government and when you have, in Uganda, we say that there should be essential medical services. Essential services that if you pay your taxes, if you're living within the confines of this country, that you should be able to access. And in fact, there is, and by the way, talking about Genius, it was a Ugandan that first came up with an essential drug list.
Yes. The one
that eventually, Charles Olaine, Professor Charles Olaine. So anyways, so you have that. And unfortunately, because we do not invest where we should, then you have all these private interests that know that
money can be made.
Money can be made, and it is being made. And because of the obvious conflict of interest, or the potential for conflict of interest, you want to avoid that. In fact, the Director General of Health Services, I think less than a week ago, maybe a week ago, came up with, now there's going to be guidelines to how close a private pharmacy can be to a hospital. That's not going to stop it. Yeah. What you need to do, instead of putting that guideline, is to ensure that whatever is supposed to be in that hospital is there. Yeah, you don't say, you can't sell it close enough to the gate, Okay. So they've been, and this is where the greed comes in, that if we are not making adequate investment in healthcare, pretty soon somebody's going to provide the alternative. And it's going to become so successful that the people that you have employed in the public facility to deliver care that you're not paying well enough are going to realize that, if I walk 500 meters down the road and I sit in that clinic, I am going to make way more money in 1 week than I make in 3 months. So what's going to keep me there? So we've created a system where, unfortunately, it's difficult to control what is public and protect what is public for those that need to use it, and to then allow those that want to have private care have it without eroding the public provisions.
Wow. Yeah. So at this point now, in Uganda's health sector today, you write this book just before COVID, 2019. I felt like you let a good crisis go to waste. If you could have foreseen the future, that there was something so big coming, you could have waited.
I actually launched it in February of 2020, and exactly a month later,
there was lockdown.
Yes.
So COVID played a very, very nasty role. As far as I think everyone who was about 15 years at that time has a story to tell. Those who were told you couldn't go to school anymore, those who lost their relative, and of course those who made big money. the greed is always there. So while it's not in this book, from your own lenses as a medic, what did you see about COVID that you can say now that the rest of us did?
Well, so first of all, when the pandemic was declared and of course the lockdown, the immediate impact on healthcare and on healthcare services. I mean, everybody, it sort of gave the impression that everybody else sit back and wait for
the big man
for the health for health services to deliver. But you see, COVID came at a time when our healthcare services, I don't even know what to say. The best time to prepare for an emergency is before it. You don't prepare for an emergency when it's on you.
Emergency.
No. So we had let the system rot. We had neglected it. We had health workers that were unpaid or very poorly paid, that were actually waiting to leave the country. We were even attempting to send them out of the country, as you read in the book, in terms of the health. So
at the same time, we're trying to bring in the Cubans.
We were doing, and that was a threat that if Ugandans don't do the right thing, the president is going to bring in Cubans and take over our jobs, and so then we'll be jobless. We better watch it. So we've done everything to frustrate the human resource, to destroy the infrastructure or to not build adequate infrastructure for the population, to underfund research. Do you know the bulk of the research funding, that's being used in Uganda is coming from elsewhere? In fact, once the Americans cut off their research. So we've done a lot to have a healthcare system that was totally unprepared for even an epidemic, never mind a pandemic. So once it hit, it really put, we were in the glare of the cameras and caught with our pants down. And so we were trying to build capacity in the midst of a pandemic. Like we couldn't even import anything because everything was shut down. And, we had fewer health workers. I mean, remember the catastrophe around ICU, intensive care units?
Yes.
There were hardly any intensive care units in the country. Now, we didn't need one intensive care unit. We needed lots of intensive care units. We couldn't produce oxygen. When it was eventually produced, we couldn't deliver it. And all manner of things that did go wrong. My one thing during that, especially the early weeks and months of the pandemic, recalling my own experience in AIDS was to protect health workers. Like I woke up every day thinking, how do we get protectives for these people? How do we get them in the right place, in the right hands? Where do we find them? Because for me, it was, there are going to be health workers that die of COVID, but they shouldn't die of COVID because they weren't protected, And so we really were battling this, monster, completely unprepared for it. And unfortunately did not improve. We eventually imagine, and now there might have been some genius, but the greed again quickly set in.
It was very visible.
The greed, I mean, really trying to profit from. So, you had people claiming they were going to deliver oxygen, that they will set up oxygen machines that they didn't. You had drugs that weren't supplied, but monies were put out. There
was a very young man from Busoga, somewhere in the mix, who was supposed to give us a medicine that treats COVID, every bacteria.
So unfortunately, a lot happened that could have been avoided if the healthcare system had been better prepared. And you would think that with that rude lesson that we would have learned our lesson. It still goes on. You still have the country under investing in health. You've just seen the budget that came out, 2025-26. And I think to not make it obvious to the casual observer, we have now this figure of 15.8% of the national budget being for human development. So in there somewhere is health, is education, is... Remember that Uganda has signed up to... not Maputo. What's the Abuja? Nigerian Abuja Declaration, yes. Where we are supposed to invest
at least, is it 4%?
At least 15%. 15%. But eventually we said maybe even 12. We've never made it. Yeah. We are hovering around 7%. So I haven't looked at the detail of that, but I'm suspecting even if we split equally between health and education, we're still going to be spending way below.
7.
So if, and you know, curiously, this budget is supposed to be emphasizing the economy.
Yeah.
But you see, you don't grow an economy with people that are sick and poorly educated and barely trained. You don't. So it's we you know, at the beginning of this book, the very first chapter, I talk about how did we get here.
Yeah.
And in the introduction, you know, I'm talking about the UNICEF report, UNICEF and Ministry of Gender.
Yes.
So a government report that says that babies that were born in 2018 would realize only 38% of their potential. I mean, that's really devastating.
Damning.
That the children are that a third of our children are stunted, and that they are malnourished to the extent that they have cognitive, you know, they're going to have problems with cognition, so they're not going to learn. These are not things that you get over by saying, I'm going to build... Over the next 5 years, my focus is going to build roads. No, you build the capacity of your population, and that population is going to build the country. It's going to build the economy. It's going to make the country run. But if you start off by stunted people that barely get an education because we didn't invest in it, it doesn't matter how, you know, so maybe if your intention is to then flood the country with foreigners, but if you really intend for Ugandans to run their affairs, you have to invest in people.
My producer is saying that time is up and there's still a lot to discuss. So there's something I want us to talk about at this point. There's this, I don't know if I should call it public-private partnerships that we're seeing now.
An example of which was Finasi Roko.
Yes, you have Roko Lubowa Hospital.
Right.
Then there's the person supposedly building a pharmaceutical company. These things, it's always government funding, but then government says we are funding a private person to do work. How do this play out? How is that possible? If I could say
that. So the public-private partnership in itself should be a good thing, and it should work. Yes. I think it's a lack of good faith that causes it to be that way. Because I think in Uganda sometimes it's really just using this entity that's created as a conduit for public money to end up in a private pocket. Yes. I think that's really what it becomes. Yes. Otherwise, there should be no, if a private individual, if Godwin comes up with a brilliant idea, but he doesn't have sufficient funding to invest in this and bring it to market, then government could come in and say, we're going to partner with you, Godwin, and this is how we're going to split the profits, or this is what we're going to put in, and this is what you're going to put in. This is not what has happened, unfortunately. Yeah. In the Lubowa example...
Yeah, you said Mulago was built at a cost of about 3 million... The equivalent of about
2.3 million,
which is about
pounds sterling, $15.7 million US dollars.
I was looking at the statistics for Lubowa, and it says that we've so far invested 1.2 trillion.
Yeah, so I'm afraid if you're looking to I think the only reason you would go to look at that is to see how can government fleece its people. I think then you have the perfect example, because it was never, right from the word go, a decent public-private partnership project. It wasn't. It was this person with their entity that was in a briefcase showed up, and government accepted, or they went to State House, and they agreed to give her the money.
Wow. Then there's this other thing that the overly privatized health in Uganda. I mean, there's privatized church. Whichever corner you move, there's a man with a speaker preaching about the kingdom of God and all that. But then I think it gets more complicated when I sit in a taxi, in a bus, or walk, especially in the slums and these areas, and there's a big loudspeaker, someone saying that I have medicine, I have cure for HIV, I have the cure for cancer, literally treating everything. There's one they call kukumanga. If you walk around Kampala in the evening, there are so many speakers talking about kukumanga, which is a magic drug of sorts. So we have all these authorities that are mandated to check these drugs for the safety of the people.
National drug authorities mandated, yes. Right.
But I get the feeling that maybe they're not doing their work, because if you have all these drugs out there, then the question becomes, are we poisoning ourselves? Are we consuming things that we shouldn't, in the name of trying to get better?
So there should be regulation, and national drug authority is mandated to do that for pharmaceuticals. But I think we also have to come back to this, common sense supply demand. If there's a huge demand for care and it's not being met, somebody is going to come up with the alternative. And so I think this is what has happened with healthcare, is that there are lots of people that are desperate to get cancer care, get care of all sorts. Yes. And they can't access it. They can't afford the private hospitals. The public hospitals don't have, the specialists to see them, don't have the medicines, don't have, if you need a CT scan, you're going to part with 300,000 at the very least. So the person then is left between having absolutely no care or buying, what did you call it? Kukumanga from the bus station.
Out of sheer desperation.
Out of sheer desperation. So I think we have to provide better care for people, and then alongside that, have better regulation. We cannot just rely on regulation when we are not providing care.
So I'm going to finish with this. The president the State House, I could say, has been in this drive of creating agencies to fight corruption. We investors in this country, I don't know if it happens elsewhere, are protected from the citizens by a special unit called the Investor Protection Unit. There is a State House Anti-Corruption Unit. I also know that there is a health monitoring unit in State House that was supposed to address the kind of problems that we saw with COVID, the grid bit of things, that is the undesirable bit. How much have they done? From a medical perspective, do you think that unit has had any success?
So I think every time you see a multiplicity of agencies, you know that is a problem, because either the agency that existed before, the first two, failed to do the job, and we think we can bring in a third one and a fourth one, or there's actually it's a deliberate effort to
undermine the two.
To undermine. So I think unfortunately this is what has happened. The monitoring unit in State House is not new. In fact, the first occupant or director of that unit is our current permanent secretary, Ministry of Health.
Yes.
And as I detail in the book, she initially went, crisscross the country, arresting people here, and all manner of things that were completely unnecessary. If you thought that at the time there was actually an entire department of quality assurance in the Ministry of Health, there was a whole department that was underfunded, that was under-resourced, that should have been doing the job that she was doing. And so when you create that and then you make this redundant, you not only are you discouraging the people here, but you're wasting resources.
Yes.
And so of course that
nothing is getting done.
No. If to her own admission, now we have huge problems that she didn't solve, and I think that the current occupant of that office is not solving, because we still haven't solved the problem. We still haven't. Yes, we need to address the real problem and not go around arresting nurses that are, doctors that sold a catheter here or some, tablets there.
Okay, thank you very much, Dr. Olive Kobusingye. This conversation could go on until the cows come back home, like they say. But I hope I can have you one of these days for the other book. Is it the correct line?
The correct line, Uganda under Museveni.
Yes. I hope we can have you for that. And I hope we can have you when you write your other book, There's when you start writing books, you don't stop. So whenever you write your next book, I hope we can have you and also discuss
It'll be my
that.
pleasure. Thank you very much, Godwin.
So, yes. So thank you very much, viewers and those who listened in. This is the book that we've discussed. The Patient. I hope you've had The Sacrifice, and you've had cases of the genius and the greed in Uganda's healthcare system. So this book is 2019. How much and where can they find it? Those that may be asking.
Most obvious in Kampala is Aristoc, but it's also in other places. Mahiri for sure.
Yeah.
Uganda Bookshop, a number of bookstores around town. And if you live in the country, it's at the airport.
Okay.
Yeah, do a search and you'll find it.
you can go with a copy.
You definitely can get it on Amazon. You can get it. You can buy it online.
Okay. And how much is it?
And you can buy. You can also buy. How much is it? I think in Uganda it's between 40 and 55,000, depending on where you find it.
Okay.
Yeah.
So please read the book. I promise you that this is a book I enjoyed. I wrote a review for it in the Daily Monitor as well. So if you get this book, it's going to give you a snippet of everything that is with the health sector from where it started to where we are now. And I hope that Doctor can get time to pick it up from there with another book after the book you're writing now that tells us from the COVID era up to now. So thank you very much for listening in and watching the very first episode. We hope to have many more. If there's a particular author or a particular book that you want us to review, leave a comment about it and we'll look out for them. We'll reach out to them. And if you're an author of a book that you want reviewed, you can as well reach out the same way. Just leave a comment and we'll reach out to you. Thank you very much. And I hope you enjoy this discussion and I hope you enjoy the ones that will come afterwards.
That's a wrap for this episode of Voice in Print. The stories don't end when the book closes. They live on in the minds of the readers. Stay curious, keep exploring until we meet again to uncover more voices behind the pages. For the latest episodes, subscribe to the YouTube channel or listen to the podcast on all podcast streaming platforms.